Begin with group A and F. I hope you've gone through the case scenario. Okay. So now it's about the clinical diagnosis. So group A.
It's a Clostridium difficile associated pseudomembranous enterocolitis. It's the patient is more than 65 years of age, immunosuppressed.
Risk factors will come little later.
Yeah. So you just identify the clinical diagnosis. Excellent.
Okay. Is it fitting to the definition of CDI?
No, does it fit in? Yes, no.
Yes. Okay, so please have a look to the definition, IDSA definition of CDI.
Okay. So it means these are key sentences that you need to keep in mind. One is the presence of diarrhea. So it's diarrhea with the passage of 3 or more unformed stools in 24 or less consecutive hours. Mind you, it is not formed stool. It is unformed stool. Plus, you need to demonstrate a stool test which is positive for the presence of toxigenic Clostridium difficile or its toxins. Either you have this, or it can be presence of diarrhea or colonoscopic or histopathologic findings demonstrating pseudomembranous colitis.
Dr. Poonam, now you tell me, is it fitting now?
Excellent. Sorry? It is unformed stool. It is not formed stool, it is unformed stool. You need to have at least 3 or more episodes, and all of them occurring in 24 hours or lesser time. Okay? And plus, you need to demonstrate a positive stool test for toxigenic Clostridium difficile or just as toxins. This is one. The second is either it is the presence of diarrhea or, okay, colonoscopic or histopathologic evidence of pseudomembranous colitis. Clear? Yes. Next.
No, now we are into the risk factors. Just list out the risk factors in this case. You all know, fast you list.
Group B few, Group G few.
We'll start with which group? Okay, please tell. Please groups, when your turn will come, before that only you be ready with the mic.
Yeah, the risk factors, you can list them out.
So the risk factors here we can divide into those which are associated with the patient and then
Very
the
good.
worker associated. So the patient is an old female who has undergone a GI surgery.
How old is the person?
She is 70-year-old.
Yes.
So more than 65.
Excellent.
And chemotherapy she has undergone makes her immunocompromised.
Yes.
Then the major risk factor is that she has been on ceftriaxone, a broad-spectrum antibiotic.
Excellent.
And an IV pantoprazole also, which actually changed the normal flora of the patient.
Protein pump
Excellent,
inhibitor. Yes.
And enteral tube feeding is another risk factor here.
Absolutely correct.
And then if we look at the healthcare worker, they were using alcohol-based hand rub for the washing, but this organism difficile is
Okay, it's a contributory factor. It does not respond to an alcohol-based hand rub. Rather, it should be with soap and water. Okay.
And the doctors amongst the group D staff, they were also not adhering to hand hygiene. It was poor. So that is another risk factor.
Okay. You have listed out most of them. Just to add, yes, there we go. It's a 70-year-old woman who the criteria is met for risk. That is advanced age more than 45 years. You said on chemotherapeutic agents, immunosuppression. Patient was on antibiotics. You said ceftriaxone, is it? Right. Then the use of proton pump inhibitors, cancer chemotherapy. This is one thing you need to focus. An ICU admission poses a very high risk, and another one is a prolonged hospital stay. Okay? And then enteral tube feeding, gastrointestinal surgery, stem cell transplant patients, okay, and malignancy. And there was one more, the use of electronic rectal thermometers, right? So this completes the list of risk factors which can predispose to a CDI.
You know this antibiotic which are high risk and low risk, please have a look. Cephalosporins are the high risk antibiotic. So next go to the...
Okay, the other organisms through contact transmission, group B. Which was the group which answered earlier? B. Now let us hear from G. Okay, very good. Okay, anybody to add to more? Okay, enterally transmitted viruses. Okay, let's have the list. You're right. There goes MRSA, which we were discussing about. Okay, MRSA. Then you have your carbapenem resistant Enterobacteriaceae. Then you have your vancomycin resistant Enterococci. You're right of the MDR pathogens. Then agents of conjunctivitis for contact base. Contagious skin lesions, scabies, skin infestations, agents of diarrhea you have already mentioned, and enterically transmitted hepatitis infections. Okay, next. Right, clear? Okay, now diagnostic modalities for Clostridium difficile infection.
Quickly you can tell. This is a very simple thing.
Now I follow you. I'm trying to look out at the crowd.
Assay is gold standard, but then it takes a long time.
Yes.
Commonly done is ELISA for detection of toxin A and toxin B.
Excellent.
Also we can do PCR.
Yes.
Short duration test is glutamate dehydrogenase.
Excellent.
Result is 2 hours.
Yes.
But again, it is not very sensitive. I mean, it has good negative predictive value. If it is negative, then we can go. But if it is positive, we should do one more test to confirm it is Clostridium difficile.
Toxin detection.
Toxin. And also, only in case of outbreak, if you want to do epidemiology, you can do a culture for ribotyping and.
Yes. There are some. Sorry.
That group, anything. The other group is?
Other group is
H. Yeah. Let them tell also.
Colonoscopy can also be done to confirm the diagnosis.
Very, very good. Very, very good. So see, here before you are the various diagnostic tests that you can do for Clostridium difficile infection. See, we need to remember one point here. A Clostridium difficile strain can be either a toxigenic or a non-toxigenic strain. Okay, so we got to demonstrate the presence of toxigenic Clostridium difficile. Okay, right. Then see, earlier people started off with these two tests. One is the stool culture for Clostridium difficile done on the cycloserine cefoxitin fructose agar, where you get yellow colored colonies with a horse bun odor. It has got a good sensitivity, but it fell out because it is very laborious and it's got a a prolonged turnaround time. Okay. The next test which came was the cell culture. Okay, cytotoxicity neutralization assay. This is a test which is highly specific, but again it had the problem of a long turnaround time. So then people started looking for rapid diagnostic tests with lesser turnaround time. So then came the demonstration of individual tests with the toxin A or the toxins A and B, and the format that they were using were either ELISAs or ICTs or latex agglutination tests. They produce rapid results, less turnaround time, but they were not as sensitive as the stool culture or as specific as the cell culture cytotoxic assay. Okay, next. Okay, there we have glutamate dehydrogenase. This is an antigen which is possessed by both the toxigenic and non-toxigenic strains of Clostridium difficile. Just demonstrating the presence of this antigen does not mean that the patient is suffering from a Clostridium difficile infection. Okay?
But if this antigen is absent,
If this antigen is absent, it's a non-Clostridial difficile. I mean, it's negative.
ruled out.
It's ruled out. Do you understand?
Yeah.
Okay. So there's an algorithm which is followed. Okay. You have the stool specimen. You screen it with for the GDH and toxin A and B using the ELISA. If it is GDH negative, Clostridium difficile is ruled out. Okay. But if it is GDH positive, you have to find out whether it's toxigenic or non-toxigenic. So what do? You go in for an ELISA which will demonstrate the presence of toxin. If it is positive, it is a presumed CDI. If it is negative, you have demonstrated the presence of GDH, but toxin is negative. What do you do next? You do a PCR, okay? A cartridge-based nucleic acid amplification test, the gene expert, okay? And if it is PCR positive, that you're able to demonstrate the presence of the toxin B gene, it means that you're dealing with CDI. If you're not able to demonstrate the the gene, it means you're dealing with a non-toxigenic carriage. It's just a asymptomatic carriage, no CDI infection.
We'll go ahead to the next question. Management. Fast, we can do D and I.
Who? D and I.
Yeah, D and I. D. Huh?
Which one? Preventing strategies will come later, right?
Yeah, preventive strategy will come later. D and I. D. Management of CDI, very simple. What antibiotics?
So metronidazole.
Very good.
Followed by
Name the two. Metronidazole
vancomycin.
and vancomycin.
Excellent.
Who's that? Who's that? Okay. First, you need to stop the offending antibiotic. So they say that a quarter of the cases get the symptoms subside when you stop the antibiotics. Okay, but there are different sets. For mild and moderate disease and for severe disease. That is what we will see now. Just the previous one. Okay, so oral metronidazole in the oral form needs to be given for mild to moderate disease, and oral vancomycin needs to be given for serious CDI infections. Okay, but if the patient has ileus or toxic megacolon, okay, which are complications, then switch over to enteral vancomycin and intravenous metronidazole. Okay, but metronidazole is most commonly used. Vancomycin should be used with a little precaution because of the risk of transmission of VRE. Okay, next. Okay.
You know this is a newly approved drug.
Macrolide, FDA approved in 2011. It has a good activity against C. difficile strains, including the hypervirulent strain and relapse cases. The hypervirulent strain, that
question is
okay.
Other treatment modalities you can read later. We can just move on, madam.
Yeah, right.
Yeah. So group D and I. The D has answered. So now I. Where is I? Yeah. Can you address
the hypervirulent strain of CDI?
It is the Vigotype O27.
Excellent, excellent.
Excellent.
Very good. Is the binary toxin BI bar North American pulse field gel electrophoresis type 1 bar the restriction endonuclease analysis O27 PCR ribotype, correct? Okay. What is special about these hypervirulent strains is they produce the toxin A and B in enormous quantity. Toxin A is about 16 times the normal strain and toxin B is about 23 times the normal strain. Okay, and they are it is marked by production of severe diarrhea. Okay, it is quite difficult to treat. So many relapses can occur with the hypervirulent strain. Okay, it has not yet been seen in India. Okay, very prevalent in Central and South America. And treatment for this hypervirulent strain is fidaxomicin. And another point is they are highly resistant to fluoroquinolones. Okay?
E and J, please come up your opinion. Yes, madam. Madam is always ready. Oh, you are going to tell. Okay, please.
Yeah, the situation in India is not as high as compared to that of the Western
Why?
countries. Why? Because there are metronidazole is available over the counter, firstly, and secondly, it's not. Yeah, it's a we Indians mostly eat a vegetarian diet, so.
So,
Lack of extensive studies is also
Indian will
not
eat
highly
a vegetarian
reported.
diet. I don't believe.
lack of various studies is also one of the major reasons.
Which one, sorry?
Lack of extensive studies and trials
Exactly.
is one of the major reasons. It is not that the prevalence is low, it is that it is not studied that much.
Absolutely.
Excellent.
Absolutely. CDI is still believed to be a problem of the Western countries, which is true, but it is also there in India. It is just that studies have not been taken on a bigger scale. Okay? So even to convince the clinician that it might be there takes a lot of homework. Okay? But you look for it, you will find it.
So these are the reasons what they have all said. Yeah. So this for observer group, you know the answer because this is something which is observer group.
Where is observer?
Can you raise hand, observer group? Yeah.
The stool has to be unformed stool. Only those samples need to be tested for the toxin testing of A and B. And pediatric samples like NICU samples, they shouldn't be surveillance, shouldn't be done on them.
Why? Okay. For the neonatal cases, it is believed that they are generally asymptomatic carriers, okay, less than 1 year of age. Okay, so it's no point test.
NICUs, like the newborn babies or within 1 month.
Yeah, and even the infants,
Yeah.
no point testing them. They are asymptomatic carriers. Okay, then, all right. So this is something which we need to see. There are many definitions as such. It is based on the timeline. Okay, a CDI positive laboratory assay. You need to have a laboratory test positive for Clostridium difficile, toxin A and or B, proven by either PCR or the ELISA or the ICT or the culture, okay, performed on an unformed stool. Okay, unformed stool. Next is what is a duplicate C difficile positive test. You have a CDI lab ID event from the same patient and location within the past 2 weeks. That is 14 days. You test again and it's found positive.
2 weeks to 8 weeks.
2 weeks to 8 weeks is recurrent. 8 weeks.
After 8 weeks.
After 8 weeks is incident. Okay. Next is a community onset CDI. It is defined as a lab ID event in an outpatient location, never inpatient or within discharge of 4 weeks, or an inpatient location of less than 3 days after admission to the facility. Then you have the community healthcare facility onset, that is if the event and the patient is discharged from the inpatient location in less than 4 weeks. Then you have the healthcare facility onset more than 3 days after admission to the facility, that is on or after day 4.
We do not do surveillance as such in India. It is not done. If you want to do, then this is the CDC definitions what you have to follow.
I think first we need to detect our
Yeah,
cases.
first we start doing for the diagnosis, then we can look for this. Okay. Thank you, ma'am. Can we just quickly go through the preventive strategy, because contact precaution is the easiest among the all three. So, group A and E, what transmission based precaution to be followed? Contact. Yes. Patient placement. Correct. Yeah, Dr. Poonam. Yeah, isolating. Excellent. Do you need a negative pressure room? No. Isolation room, or in absence of a isolation room, Indian situation we don't have isolation room, then cohorting. Excellent. Okay, make sure that there is no contraindication for cohorting. Okay, pair of all these are various type of cohorting, and please maintain 3 feet distance. All this. There is something called as a visual cue, or such as color tap placed on the floor. So, like in some hospitals, they will level the bed as MRSA. Okay, you can name it as MRSA. Otherwise, you can just put some red color sticker on the case seat, on the tap, colored tap surrounding the bed, so that these are the high risk areas we have to follow precautions. Hand hygiene, Clostridium difficile disease, so you have to have soap and water. When to perform, you all know. Sickle of removal also, you know. Hand wash or hand rub? Excellent. CHG or alcohol? CHG. Excellent. What PP? Contact, because only 2 PP. They are? Excellent. Gloves and gown. Okay, that's all. Gloves and gown. Patient transport. What are the precautions? Fully restricted or limited restricted, or no restriction? Limited restricted, only for medically necessary purposes. Okay. Otherwise, the movement should be restricted. What advice for the patient? Patient should be on hand hygiene and PPE. Transporter should remove and discard the contaminated PP and perform hand hygiene prior to transport, and then wear clean PP. Okay, so that has to be done. What advice for the receiving unit? Very often we forget to inform the infectious status to the receiving unit, which is very bad. Okay, so we have to, as the clinicians, it is their duty to inform the isolation status to the receiving unit. Patients and family members. Okay, so you have to educate them. If the visitors are there in the isolation room, they also have to use the PPE. If they are staying in the patient room, use of PPE all the time is impractical, because they will stay inside the room all the time. So best is hand hygiene, 100% compliance, because when it comes to contact precaution, hand hygiene has to be nothing less than 100%. Okay, daily bathing of the patient. So these are the few other things. So antimicrobial stewardship, because it is antibiotic overuse, so you need to regulate that. Disinfectant use for the surface, equipment and environment. CDC says hypochlorite is the recommended disinfectant. Please remember, these are spores, Clostridium difficile spores, so it may be there in surfaces, various high touch areas, commodes and the bathing tub. So those are the high risk areas which has to be cleaned. Toilet. Okay. So these are the various areas. This slide shows the various areas in the isolation room where you have to follow the disinfectant. Any questions are left? So these are the high risk areas. Oh, this picture is not clear. Dr. Davani has shown this same picture in his slide. So every patient is purple. I mean the background is not there only. So maybe I will click and I will send in the group. Okay. So these are the some areas we have to do for every patient. Some areas we have to do in for the limited patients. So that is the thing. So yes, as I told you, the effective product is 1% hypochlorite by CDC. Yeah, that is a risk factor. That is not recommended. You should not use. Okay, we will ask that tomorrow. Okay. So monitoring the disinfection cleaning. So you have to do the these are the various. Tomorrow also we do have posters. Tomorrow is the longest day among all the 6 days. Come, listen, we'll start. We'll